Good day and welcome. Thanks so much for joining us. I'm Michelle Levander, Director of the Center for Health Journalism. We're going to be talking today about the future of the individual exchanges. Yesterday saw just the latest development that raised doubts about the stability of this linchpin of Obamacare, which allows individuals to get a uniform set of benefits regardless of whether they're in good health or poor health. Anthem, one of the biggest players in the individual market, announced it was pulling out of Ohio's marketplace in 2018. Should Anthem exit from as many as 13 other state markets in 2018, it could leave hundreds of thousands without any insurer in their state exchange. Are Obamacare's exchanges collapsing, as Republican leaders say, and what are the reasons why? And what do reporters need to know to bring this story to life in their communities? This webinar is offered thanks to the generous support of the National Institute for Healthcare Management Foundation. Here to help bring this home are three distinguished speakers: Catherine Hempstead, who directs the Robert Wood Johnson Foundation's work on health insurance coverage. She works on issues of healthcare price transparency and value, and also serves as visiting faculty at the Rutgers Center for State Health Policy. C.C. Connolly, the President and CEO of the Alliance of Community Health Plans, which represents not-for-profit and member health plans that provide coverage for more than 18 million Americans. Previously, C.C. spent more than a decade in healthcare, first as a national correspondent for the Washington Post, and then in leadership roles at two international consulting firms. Chad Terhune is the senior correspondent for Kaiser Health News and California Healthline. He previously worked for the Los Angeles Times, the Wall Street Journal, and Business Week. For a number of years now, his reporting has focused on health insurance and the business of healthcare. Before we get started, I wanted to share a few operating procedures. We'll hear first from all of our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. Should you want to tweet about this webinar, the hashtag is ACA Exchanges. Now, let's get started. Catherine, do you anticipate that Anthem will pull out of the other 13 states but remains a dominant player? And what does Anthem's decision tell us about the challenges ahead for the exchanges?
Hi, good afternoon, everybody. I think it's unlikely they're going to pull out of all the other states. In fact, they've filed in a couple of states, although they could revisit those decisions, and they could also revisit their Ohio decision. I think it signals that they're very frustrated with the current uncertain environment, and they, don't see a promising path forward right now without some clarity from the federal government. So I think this is as much a kind of political comment as it is a statement about their financial performance, which looks in many of the states like it was relatively good, including Ohio.
Thanks, Catherine. And just a reminder, when you get started, to press accept so we can see your slides.
Okay. Well, hi, everybody. I just wanted to talk for a couple of minutes about some of the things that I certainly concentrate on and that I think that reporters that are covering this issue might want to be thinking about over the next couple months at least. And I sort of wanted to start by framing things up because I think there's such a time frames that are relevant. And so I just, wanted to start out with this little perspective, thinking about, some of the issues are really very immediate and have to do with the open enrollment for 2018, which is just a few months away. And then there are things that are, very important, repealing and replacing the ACA, those efforts and other things, but they're not really going to be implemented, if at all, for a couple of years. And then I think there are a lot of interesting sort of bigger picture out of the box conversations that are going on about health reform, which I think would really require probably, national elections to really move any of those things forward. But all these issues get covered kind of at the same time. But I think it's worthwhile kind of thinking about what are the things that are really the most immediate and what are things that have a little bit of a longer time frame. So I thought I would just talk about, a little bit of all of them, but I'm really going to concentrate on the sort of market conditions in the states. So the kind of umbrella environment for a lot of the conversations that are going on lately are the efforts with the new administration to repeal or replace the ACA. And I think that is something that, it's very hard to know and prognosticate exactly what's going to happen. It seems like the last 24 hours have made many people feel a little bit more optimistic that the Senate's going to be actually able to get votes and pass something. There have been, some signs of progress and some sort of positive comments from various people. I think it's, certainly too soon to say, but I think that people feel more optimistic about the possibility that something is going to get through the Senate and get the required votes than they did, even on Friday. So that's something that, bears watch. Have a lot to do about the fate of the individual market in the states. The other big national issue that is just kind of rotating right now and nothing very satisfactory is happening right now is the issue of paying the cost sharing reduction payments and the any kind of federal solution to the potential and actually right now the actuality of having counties that don't seem to have an insurance carrier right now for 2018. This has been, I think a lot of fatigue about this issue now, and everybody is frustrated, and there's just a lack of any kind of clarity from the government about what's really going to happen. It seems like, the White House has signaled that they don't want to make the payments. Many people feel like ultimately Congress is going to have to appropriate, but there's just no sign that anything constructive is going to happen. And there is going to be sort of a hard stop sometime in the summer about this. So now we're starting to see carriers and insurance commissioners kind of, pricing for having those payments and pricing for not having those payments. So this is something that's just sort of not really moving, but is obviously extremely important. And there are a couple of federal, people in Congress have talked a little bit about ways to address some of the market instability that we have right now. The bill introduced to, talk about whether to allow people with no carrier to potentially use the what's happening in the States. So then I think the issue, and I forgot to credit Kaiser Family Foundation. I stole their map just to have a picture for this slide. But the thing that I think everybody is talking about a lot lately is sort of how that sort of, national context filters down to the states and what's happening in the states as they try to come to grips with what's going to take place in their individual market next year. Because right now we're in the season where all the rate filings are taking place and the carriers are saying whether they're going to be in or they're going to be out, and providing a rate and various other kinds of important details. And as I'm sure many of you have been following, there's been quite a bit of sort of unfortunate news that's been coming out from the carriers in the last little bit of time, and the anticipation that more could come. So with the idea of sort of providing some ideas and some sort of destinations for information about things, I think if you're following this topic and you're working in a state or a region, it would be probably interesting for you to be like reading the rate filings from the carriers and being aware of when the rate filings are happening. There's there are various places where you can go to track the rate filings, and then I think the rate filings themselves are very interesting to read, although, I mean, not everybody would think a rate filing is that interesting to read. But I think there are a lot of clues in rate filings sometimes. I think it can give you some perspective into what carriers are thinking. They also sometimes use rate filings to make sort of commentary on how they feel about certain issues. I think a good example of that was the recent filing by the Blue Cross Blue Shield of North Carolina, which was a kind of notorious rate filing because they very, very explicitly mentioned the sort of the difference in their rate, whether they, would be counting on the cost sharing reduction payments or not, and what a difference that would make in their rate. And they actually had a fairly reasonable requested rate increase, if they were going to get those cost sharing reductions, and then, a very different number if they were not. And then shortly thereafter, the Pennsylvania carriers did their rate filing and also did something quite similar, where they made it very explicit, sort of the price of not having the cost sharing reductions, and just the frustration with that uncertainty. So far, most of the states haven't had their rate filing. So there are some, maybe, I don't know, about 8 or something might have filed already, 8 to 10, something like that. But you can look and sort of follow along and read the other ones when they come in. In more leisurely environments, when it's not such a sort of a crisis atmosphere, that's another really good time to look at things like, what plans might be discontinued or reintroduced, or how benefit designs might be getting changed. Some carriers will say some things about their experience with different products, and you can actually, get quite a bit out of them sometimes from just like understanding the plans and how they work. It's a really good information source. But, right now, I think mostly people are looking to see our carriers in or out, and how much are their rates going up, and what are they saying about CSR. So that's all in there too. And, for them to potentially refile, even for 2018, I think, if conditions warranted that. So I think that was extremely provocative, and chances are they won't refile. But it was another sort of a variation on the this opportunity that the rate filing deadline on, and what they think about things going forward. So I think that's a very important data source that I'm sure you're interested in, but I would encourage you to look at rate filings. You also can see, just as a kind of FYI, you can see rate filings on the healthcare.gov site. You can also look at rate filings for non-ACA compliant plans, which you might not have ever really been that interested in looking at before. But if you're following a state where they have a lot of transition business, it's kind of interesting sometimes. If they have a significant rate increase, they have to do a rate filing for their transition business. And so you can sometimes learn about that and how big it is, and get some information from those rate filings that might be valuable to you, depending on where you're covering. So another thing that a lot of people are interested in talking about right now is how are the carriers actually doing financially? I mean, before this issue with the cost sharing reductions and the other ways that maybe people are trying to sort of undermine the market right now, the market had problems before that, and many people looked at the big rate hike in 2017 as kind of a reset, and we're really hoping that a lot of carriers were going to kind of right themselves and perform better, and have a better experience in even 2016 and maybe in the beginning of 2017. And I think there have been some interesting articles that have come out that have I think provided some support for that. There was a very influential report from Standard & Poor it came out in maybe April or something like that, that looked at some 2016 financial results from carriers. I think it must have come out right when the SHCE came out or something, or the Supplemental Healthcare Exhibit, and showed that a lot of the Blues, it really focused on the Blues. A lot of the Blues had kind of turned a corner, not that it was wildly profitable by any means, but that a lot of the Blues seemed to be doing quite a bit better. And then, very recently there was a piece that took from Bob Herman and Axios, who's followed the Blues for a long time, and he used to write some great stuff about the Blues also when he was at Modern Health. But he wrote something about just looking at what's available for 2017, because believe it or not, even though it's very timely, you can get Q1 2017 financial statements from your carriers, from the National Association of Insurance Commissioners, and I think they either give them to the press free, or they just cost a couple dollars or something. You can get the PDFs and look at them. And you can see, if you want to focus on the individual business, it's limited what you can see, but you can see enrollment, member months, premiums written, claims, and you don't get to see like the claims adjustment costs and stuff like that. But you also can, they have to put in a few measures of utilization, which I think are a little bit sketchy, maybe in terms of how careful that stuff is, because those numbers don't always seem like they make a ton of they say, but you can get a sense of what their experience was like in the first quarter of 2017 in a very rudimentary way. You're not able to separate transition business from QHPs because it doesn't report at that level of detail. So if the carrier you're interested in has transition business, that's a problem. It's all lumped together. But I still think that's a really good data source if you're trying to see, how are the carriers in my market doing, especially ones that are maybe talking about exiting, et cetera. And I'm working on, I think, these last few months have been difficult for all states, and not getting the CSR payments is, not good for any state. But I also think that it's important to understand that a lot of what happens in states is not random and sort of has to do with some sort of state characteristics. And I think there's some really important state characteristics that they can't control that well, like being, having low population density, poor health, low income, uncompetitive provider networks, so things are expensive. So those are sort of, structural things that states, put states at a big disadvantage. But then I think there's some policy decisions that states make that are, either helpful or not in trying to have a viable market for qualified health plans. So, states that didn't expand Medicaid, that wasn't good for the risk pool in the individual market. States that permitted transition products, and I think that if you read about a place like Iowa, it's a really great example where they have more people in a transition product than they have in the in the qualified health plan market right now. And it's their Blue that has a big transition product and then exited the marketplace. Having a history of sort of limited coverage specialists, allowing people to sell like limited short-term individual market coverage in their state is something that if states did a lot of that before the ACA, they didn't do as well, and some states still do it. So that's another thing you might look at if you're covering a particular state is, does my state have a lot of these state risk factors? Does my state allow a company like Freedom Life Insurance or whatever to sell in my state? And, what are the experiences of people who have bought policies there, and what's that like? And, I think you certainly see that states that have a lot of these risk factors then are more likely to have, what you would consider sort of adverse market outcomes, which might be, bear counties, or the possibility of risk of a bear county, larger than average premium increases and low turnout. So these are all things that are related. And this is, relates to just another issue that, I've been thinking about a lot and is important, is this sort of issue of, leakage, or things that allow a lot of the, population that should be in the risk pool to not be in the risk pool. So I think that it's a big issue, and it's a complicated issue, because I think states that have permitted a lot of leakage, it's not that they don't know that they're doing it. I think it's also reflects just some different philosophies about, consumer protection and what insurance should be. And it's, it's very to buy other kinds of coverage. So I think that this is a very big quandary in some states, and it's just not a factor at all in other states that eliminated transition products and did not allow limited coverage specialists to sell. So I think that those are some really important things to think about, how different state experiences are. This is, we're putting out a little report today, actually, and this is just a table that, it's probably too small to really see, but it just shows in 2013, the percentage of individual market carriers that were sort of quote unquote limited coverage specialists, who are like people that, primarily don't sell QHPs and didn't stay in the market to sell QHPs later. And you can see that there's a lot of variation. And even back then, there's a small number of states that, didn't have any of that participation, but that a lot of states, it was a really big part of their marketplace. And then if you look at this, I think this is kind of an interesting figure too. And it just sort of shows that over time, when you look at who's selling insurance in the individual market, at the beginning of the time period before the ACA, there were a lot of limited coverage carriers and national carriers, and really, sharp decline in both of those and a lot of volatility with those, but that there's been a really kind of steady and increasing participation, slowly increasing, but steady and, increasing at least a little bit, of Blues, regional carriers, Medicaid MCOs, and provider-sponsored health plans, which are really sort of the backbone of the ACA compliant market. And that these, there's been a quite a shift in the composition of the market. But if you looked at individual states, you would see that states that had a lot of limited coverage participation before the ACA were less likely to provide an atmosphere that was really attractive to some of these other kinds of carriers. And I think when there was a lot of sort of leakage out of the market, it was, it wasn't really conducive to creating a good market to sell QHPs. So there's a lot of interesting sort of, market structure things. And then this just shows what that looks like today, where you see many fewer states allow limited coverage specialists to sell, but some still do. And I think if you look at who's having a problem in their market, chances are that they allow a lot of things that are conducive to leakage and getting people to buy, non-QHPs, or allow people to stay on transition products. Another thing, so I guess that's sort of what I would say about market conditions. I'll just wrap up fast in case I might be going over time here. Other interesting issues that you might be following in your states are some of the initiatives some states are taking to either stabilize their market. So there's a handful of states that are trying to create reinsurance programs, either through a 1332 waiver or not. And apparently CMS is really, encouraging states to do that, and are even telling states it's not too late yet. You can still try to do it for next year. So there's, Alaska and Minnesota have worked on this. Oklahoma is, done some stuff. I think Maine is a little bit interested, maybe some other states. So, but it is necessary to have a little bit of state money to kind of throw in the kitty to get this started. So it's something that, states need to be willing to do. And then, other states you may have noticed are doing things like New York just put, Cuomo announced a bunch of things like that he was going to require essential health benefits be, part of all the plans, like sort of trying to fortify the state against things that, that might be happening nationally. So there are interesting things that states are doing. And, so this is just kind of a wrap up. If you're covering the individual market in states, these are some of the things that I think you might find are good ideas for stories. And then at the bottom is kind of the luxury item. If your market's not in free fall, dysfunctional chaos, you can look at things like, premium and benefit design changes, new networks, kind of the things that used to be interesting news sort of when things were a little bit more stable. And then at the bottom, I just put a link to a data set that we have at the foundation called HICS Compare. That's a plan level data set that has, a lot of information about the characteristics of plans, and, glad to talk to anyone about that offline. And, just my final slide, I think, there are a lot of other sort of fun, interesting things that people are talking about at the national and state level that, definitely at the national level would, take some changes, but, you're hearing people talk about different kinds of Medicare buy-ins or Medicare Advantage for all. Nevada just promoted an idea about allowing people to buy into Medicaid. That's something that I think Minnesota had considered having that be true for their basic health plan. That's not necessarily as far-fetched. California has a single payer proposal. So there are these other sort of more out-of-the-box kind of ideas that people are talking about that are, also really interesting and important, and good ideas for stories too. But it's hard to, at least for me, it's hard to kind of avert your gaze from the things that are, so pressing and are happening kind of immediately. But that's, I think this shows it's a very sort of active time for people that cover insurance. I believe that's my last slide. Yes. So thank you, everybody.
We're going to turn now to the situation is evolving so quickly. How do reporters and policy players for local and national communities stay ahead of the curve?
That sounds pretty impossible, but we can try. I liked what Catherine was talking about, kind of short, medium, and long term. It's kind of impossible to deal with all of these all at once, but kind of take kind of certain bites that we can digest. And I think unfortunately I am in the minority that Catherine described. I do like to read rate filings. But I just wanted to share some thoughts from a reporter's perspective, and thanks for having me on here. Obviously, as we've talked about, kind of teasing out, what is the Trump effect on 2018 premiums? I think there's been a lot of talk about the cost sharing subsidies, which is legitimate, but I think some people are not talking as much about the individual mandate and the Trump administration pulling back from that, not enforcing that. And you see that in some of the rate increases that are coming out, kind of baking that in, that'll have an impact on rates. And then just lastly, just as a business reporter, don't let insurers off the hook on rate increases. Don't let them blame everything on Trump, that we still need to kind of scrutinize Carolina was a really nice breakdown of what they were looking, and you'll see there's some other examples, and we do see a lot of similarities. So just kind of like the base rate increase, what we would deal with in like a normal year without all this uncertainty, they were around 9%, but then they had the cost sharing reduction money not being there. The health insurance tax comes back for 2018. So that got them up to 23%. And I thought the CEO had a really good quote, just kind of bringing it back to people's pocketbooks. And just as a reporter, we need to keep the focus on that of, these are real financial issues for people. They're trying to pay their rent, for groceries, gas, and health insurance is just one other cost they're having to shoulder. And then also in Pennsylvania, she mentioned kind of a broader sample. We had 5 insurers, and again, very similar number, about 9% would be the basic increase. But then when you add in the other things with cost sharing and the mandate, it went up to 36%. And then California kind of did some similar math. Again, they had a base increase they were projecting of 9%, and they even broke it down between 7 kind of base, just regular cost of care, 2% from the health insurance tax, and then they had this higher estimate of 42%. So you can kind of see a pattern, kind of 8 to 9%, kind of the normal increase, and then we have this much higher number tied to the cost sharing subsidies and the mandate. But again, if we go back to that base increase, 8 or 9%, that's still kind of the recurring problem we have in healthcare, because that's certainly greater than inflation. Nobody's wages are going up 8 or 9% every year. So that's kind of the recurring problem we have in healthcare. And then that gets us back to what I think we still need to do as reporters is look at this medical trend. And that's where Catherine was talking about looking at the rate filings, and that's where you get the insurance company actually breaking down, why am I raising rates? And you're looking at doctors, hospitals, and drugs, and like who are they pointing to as who or what is driving up costs? And so you'll usually have the different buckets of doctors, you'll have prescription drugs, and then usually there's 2 different things. They'll look at use, like are more people going to the doctor, or more people using prescription drugs, and then the price, or the price of those services going up. And the example here for Anthem in California for this year, for 2017, so last year's rate increase, they were pointing more at prescription drugs going up about 8 or 9%. And then I did a story last fall where some consumer groups were kind of questioning that. Like, really? Are drug costs really still going up that much to justify this rate increase? Because they were still citing things like hepatitis C, and a lot of those costs had fallen year over year, that had subsided. So those are always good things, just to hold the insurers accountable for their explanation here. And then just, more questions to ask, what else are insurers doing to control costs? Most communities are still going to have maybe a big dominant hospital system. What are they doing to push back? You can have tiered networks. Are they trying to make it cheaper to go to a preferred hospital that might have lower costs, better quality? In-network benefits, but you have no benefits out of network. That can cause some problems for consumers. Bundled payments, obviously prescription drugs is still a big issue. Are they pushing back on some big new brand name drug that came out? And then, kind of nuts and bolts things, do they let members shop around? Do they actually give them price information in advance before they get an MRI? Kind of things that insurers talk a lot about, but are they actually doing some of these things? And so every time there's a rate increase, these are just some of the things I want to hear about. And then this was a more recent development and could be a good local story. There's been a couple of different stories, one in the St. Louis paper and the Atlanta Journal-Constitution, where Anthem was trying to make it where if my child bumps her head, I take her to the ER, but after the fact, it was deemed non-urgent. It wasn't an emergency after all. I could be stuck with the ER bill. So that raises all sorts of consumer issues. But certainly for Anthem, they're saying, look, we're trying to hold the line on costs, and this is one solution we're looking at. We talked about the Bexar counties, because obviously if rates are going up, it's less of an issue if I have, option B or C, if I can shop around. There's a lot of good maps out there that kind of show the state of play. And then just anytime we're writing about the individual market, to me, we just kind of need certain reminders for readers that, look, we're talking about one slice of the market. Most people still do get their health insurance through work, but remind people, all of us can end up in the individual market someday, laid off, change jobs, start a business, you retire early, everybody could be in this market at some point. And, the research shows a lot of people come and go, a lot of churn. And Catherine was talking about this, looking at the filings. Insurers make money a lot of different ways. In individual market, there'll be a lot of talk about the losses. Those are legitimate, particularly for certain companies that are very exposed to this market. But just keep in mind, look at their overall net income and profits. Insurers, for the most part, still can find a way to make money. So just, keep in mind kind of the and just in the line of, well, this really doesn't matter for a lot of consumers because subsidies are going up too, which is true, but I think it misses the broader point that this is still more money being spent on subsidies, and you and I as taxpayers are paying for this, and just kind of goes to, affordability, and money that's going to healthcare is not going somewhere else, perhaps, education, roads, other things we as a society, think would be pretty important. And then just a step back on that, we'll talk a lot about rates, but just, keep in mind, look at your local insurers. How are they doing on just general customer satisfaction, prevention, treatment? National Committee for Quality Assurance has some great stats annually where you can look up your local insurers, you can sort it by state, and, it's just a good way to check, how are they overall doing? And yeah, Medicaid, I think we write a lot about the exchanges. And again, that's very legitimate. New York, basically saying, look, if you're going to exit the exchanges should you still have the ability to get these Medicaid contracts. So I think that's a great story at the state level of, okay, state officials, are you going to draw this line? Because increasingly that is happening. The same companies exiting still want to keep these contracts for Medicaid managed care. And I think that's a legitimate policy debate to have. And then just other ideas, people to look at. Actuaries might sound like a really boring person to profile, but I mean, they are at the center of all this, trying to make sense of all this chaos. Often think health insurance agents are still often overlooked. They're a great source for ideas. Their ears to the ground. They can get you in touch with people right away. I'd want to know, what are the questions they're getting as people are streaming in or calling them on the phone. In terms of the young and healthy people we always hear about, we want those people in the market. Go to a local soccer field, interview, a bunch of 24-year-olds. Do they even know what's happening? Are they paying attention to all this? And then if you really want to light up your inbox, write a story that has both immigration and healthcare in it. Because certainly Trump's talk on immigration, is that making people who have mixed status, like some people are documented, some are undocumented in their family, are they worried about renewing their coverage, staying in the market? And this is some examples. Anna Matthews at the Wall Street Journal, I thought, did a great profile of an actuary at Blue Shield of California way back in 2012, as they were trying to sort through everything. And to some degree, to me, we've kind of gone back to that time period of like 2012, 2013 of just all this uncertainty and kind of throwing a dart on the dartboard. Same thing with agents. I just think they're a really overlooked source. Some other sources, there's a lot of benefit consultants out there that can help you make sense of all the numbers, put them in perspective. Mercer and Milliman are two ideas. The rating agencies, they do a lot of good research on the nonprofit blues that are dominant in a lot of states. And, like I said, there's a blizzard of news. So these are just some ideas for journalists, experts, other people to follow on Twitter, get on their email list. It just gives you an easy, quick read on maybe what is happening. And I think we have to be careful, to get outside the bubble of people who are just ACA supporters, make sure we're hearing, a wide, diverse view, getting people who are both pro and, against the ACA. And there's some links for some of the stories, and, feel free to contact me anytime if you want to just talk story ideas or, how to approach the reporting. And thanks again for having me.
Thank you so much, Chad, for all these tips. Cece, we're going to turn to you right now and wondering if you could share a little bit about the thinking of your member health plans, about their decision making, about their participation in the 2018 exchange markets.
Yes, absolutely. I'm just switching the screen here so we can get to the start of my presentation. Sorry, tell I'm a former journalist and not so. There we go. Great. There we are. Okay. So hello, everyone. And I realize we're short on time, and I'm sure you would much prefer to get to questions. So I will go very quickly through. I was asked to just do a couple of slides. So first, I think it's important for you to know a tiny bit about the Alliance of Community Health Plans and who I'm speaking on behalf of, because it is very certainly not the entire health insurance industry. We are a consortium of nonprofit, provider-aligned, community-based health plans. You could see our members up on the screen here, but those unique attributes have a very significant impact on the business decisions that our members make, including around things such as the individual market participation, rate filings, et cetera. For a bit of context, I can tell you that most of our not-for-profit members last year had margins on the order of 2%. So really operating on very narrow margins, and that's who I tend to speak for. just to capture the many things that are in play at the moment, and you know this because you're trying to cover so many of these different stories, but for nonprofit health plans, of course, the individual market and stabilizing that is really priority number. That rely and get the questions from them about, well, will my coverage and care be the same and will it be available next year? So this is an immediate threat to those working families and by extension, many of our plans. But the broader issue of uncertainty about the future of health reform, it is exceedingly difficult for any business to operate with this level of uncertainty. Chad has mentioned the actuaries, God bless them. They do their best at trying to model and forecast different scenarios, but with so many unknowns, it's very, very hard. Based on the House legislation, we are now increasingly focused on the future of Medicaid, and I'm happy to talk some more about that. And finally, affordability and accessibility. The more that you discuss pulling support, financial support programs out of the system, or reducing them significantly, what you are going to do is create greater access problems and obviously greater affordability problems. And those are enormous elements, again, for our nonprofit community plans. With respect to the individual market, and I have to say here, there are two ironies in the current discussion on the individual market. The first irony, of course, and others got at this already, but it's such a small slice of the total U.S. healthcare system. And so much time and energy and hot air and pencil sharpening has been devoted to this. Not to say that their coverage and care is not vitally important and it's become yet another safety net in our society, but there is an irony with the entire health system. Individual market was indeed stabilizing in many parts of the country, not absolutely every county or state, but many. And one of the things that we've heard from so many of our member plans and the CEOs is that they were really starting to apply some good learnings about this population, about their health conditions. They were starting to have high retention rates, which was very good from a managing a health perspective. And they were actually starting to bring some of the cost, the medical cost trend under control because of all of those learnings. So it's ironic that now we could be in a situation of disrupting that entirely after it had finally settled down and stabilized. So that's a pretty unfortunate development of the past few months, I would suggest. Many of you may have seen this map before, but when you're thinking about those cost-sharing subsidies and where they would provide the greatest assistance, this is a very handy one, and I can tell you it's a map that certainly many members of Congress, when we go in and talk to them, they want to take out their bifocals and scrutinize this map pretty closely. So a couple of the specific questions that were posed to us preparing for this presentation. One was on the question of how can reporters build relationships and really get after the good stories that are out there. And so this may look a little bit as though I'm kind of stating the obvious, but sometimes I think it's worth kind of reinforcing here. And I always say to people on the other side in the industry, I always say to our CEOs and our communications folks at the different plans that, you know, reporters are people and you should approach it like any other professional relationship and take the time to build those relationships and get to know each other. It's very difficult whether you're on the reporting side or the interviewee side if the first conversation is a very difficult, challenging, uncomfortable conversation. So I certainly encourage all of you to try to do that outreach when you have a few minutes for a cup of coffee, to just get to know each other first, understand the business, what they're about, how they do what they do, and then kind of build from there. State Medicaid officials, but in particular, what I wanted to highlight are former state Medicaid officials. There are many of them out there in the world today. Some of them advise health plans, some of them are at think tanks, some of them run their own consulting businesses. They're very, very smart. They have been down this path. They're a little bit freer to talk candidly. I always found as a journalist that somebody immediately out of a position was often a little bit more at liberty to share their thoughts. And so I would certainly encourage you to seek out those experts who are still quite plugged in and knowledgeable. Certainly academics, from a kind of analytical perspective, there's phenomenal interest right now in healthcare, and every university that I'm at, you are finding entire centers dedicated to looking at our health system and trying to improve it and make it better. And there's really no and developing those relationships, maybe even potentially posing some questions to them that you'd love some help kind of thinking through. They tend to be very readily available and interested in chatting. Somebody earlier mentioned NCQA, which I think is a great resource. I would also just mention, because they came out with a report just the other day, J.D. Power, looking at really health plans more in terms of how they perform on customer service. And this is historically an area where the health sector in general, and probably insurers in particular, have been pretty lousy. You know, frankly, they're right down there with journalists. And so to take a look at the 6 factors that J.D. Power drills down on with respect to customer service is worth it. And the interesting takeaway from this year's study is that they see much higher performance and much greater satisfaction in those integrated systems with a plan. And I think there is a growing body of evidence around the value of plans and providers working much more closely together. So whether in a fully integrated system or just that close alignment, I think that's really where you have the potential to improve health outcomes and start to get a little bit of a grip on the cost situation. And finally, what are the untold stories? So I would really encourage everyone, and I know this is probably the case of many of you already, but try to step away periodically from the Washington drama or melodrama or soap opera or whatever you want to call it. Because A, it moves at a glacial pace, so you can probably step away for a little while, come back and be able to get right caught up again. And also because, you know, it's kind of like the 8-year-old soccer game where everybody's kind of glommed around the ball. And the old adage that certainly I always heard from editors about zig when everyone else zags still is extremely worthwhile today. So I tended to get on the front page of the Washington Post much more often when I left Washington and I went and I wrote about an interesting system that was doing something innovative or where there was a success story or the opposite, but it was often where something was working. And so looking for those stories, people are really interested in that and how they're doing it and why. The question of who is served, so really understanding the Medicaid population. One of our concerns right now with the current debate is that everyone is kind of putting Medicaid beneficiaries into one single category, and they're not at all. There are many, many distinct subgroups within the Medicaid population. And as people put out policy proposals, you've got to sort of put the lens of the different subpopulations up to the policy proposals. Health complexity, that has been a major handicap, frankly, in managing the individual market to date. Patients with multiple chronic conditions and also often behavioral health challenges, socioeconomic challenges, could be addiction. And so when I talk about health complexity, it's those kind of individuals that are so hard to serve and care for efficiently, effectively. Highlighting in your community that lack of transportation, lack of quality water, not having access to the internet, these have as much to do with the health of an individual and a community as candidly just about anything going on in the hospital. And so really stepping away from health care and focusing on health will generate some fantastic stories. So with that, I encourage you to reach out to us anytime at all.
Thank you so much, Cece. We feel really fortunate that we have someone like you with this dual expertise in journalism and healthcare, health insurance industry. We're going to turn now to our audience and ask them to share questions. You can enter your question on your control panel, and we'll be picking questions from you. Cece and Catherine and Chad, we're running a little behind. Can you stay an extra 10 minutes so we can have 20 minutes of questions?
Yeah, I've got 5 or 10. Yeah.
Okay, great. So I'm going to start out, Chad, with a question for you. I know that you try to be very strategic in dealing with the uncertainty of where things are going, and yet being set up to have real people who you could call on deadline who fit certain categories. Can you tell us how you do that?
I wouldn't say I always succeed. I mean, certainly with something like cost-sharing subsidies, you can line up a lot of those people. I mean, more than anything, I want to identify the person. I want to talk to them, kind of, make sure I understand, where they're from, what they do for a living, how long they've been enrolled, get all the basics out of the way. And then if something happens, then I can always, call or email them and say, hey, this just happened. Or certainly like with rate increase stories, I mean, oftentimes the deadline or it's going to be announced, on this Thursday, and you can line up those people in advance. So I guess that's what I try to do. Sometimes, news happens and you just need to do the story. You can't really find that perfect person, but there's certainly some of that kind of what I call pre-reporting to get ready. And then, just tell the person, look, I might reach out to you on deadline. What's the best way to reach you?
And Cece, if you have a tip in the similar vein from your reporting days, feel free to chime in on that.
Well, again, I would certainly often turn to a lot of the consumer groups, patient advocacy groups. They tend to be close to the ground on that sort of thing, although I think now journalists are probably using social media much more effectively to post, I'm working on a story about this, and finding people. And that's a new tool that really did not exist when I was reporting.
And so return to some questions from our audience. This one's not directed to anyone in particular, from Michael Morris. In the Senate, are we headed toward a choice between preserving exchanges or maintaining Medicaid?
This is Cece. Great question. I've not heard anyone setting it up as that sort of a trade-off. I think that one of the most reduce the deficit by the same amount as the House bill, unless they come up with a very convoluted parliamentary maneuver around that. But if they kind of follow the rules that they ought to, they need to reduce the deficit significantly. That makes it hard to, quote unquote, lessen the reductions in Medicaid, for instance, which we know for a fact a good number of Senate Republicans have a desire to do. So making the math work in the Senate is becoming probably the one of the biggest challenges.
So just a reminder, you can type your questions into the question box on your control panel. We have a question from Michelle Faust. Is California unique in allowing more than one rate filing this year? I'm curious whether this will help ultimately, considering the new rates will be announced before Congress will likely have a plan. And did this approach in California actually contribute to the uncertainty in the market?
This is Chad. I think other states have started to do that in terms of asking insurers maybe to have two sets of rates. I think it has a practical reason. It does help to kind of see what would be kind of the kind of quote normal increase, so you can kind of check those numbers. It obviously has a little bit of a political point, and I think people have talked about that as you're really kind of showing Washington, look, you guys need to get with it. This is what's going to happen if you don't get your act together. So I think other states have started to do that, whether it really changes things in the end. I mean, I think it'll be interesting on the back end when we finally do have final rates. Do they still present two sets of numbers? And, I would want to see all of that.
Yeah, my understanding is that state regulators are really trying to be quite flexible under these very challenging circumstances around the individual market filing. And so we've heard from a number of our members that they're having very positive, constructive dialogue with the state regulators, whether it's having two filings or being told that they'll have an ability to revise in light of any action that may come out of the Senate, et cetera. And I think it's I agree with Chad on the motivations. I would just say that I think that state regulators, again, who are very close to the ground, and they appreciate just how much chaos we could have if those cost sharing reductions very suddenly disappear, and it's going to be chaos in their home markets. So they're really trying to kind of keep everything as steady as possible right now.
We have a question from James Chisholm, who asks, why is there so much more coverage for the ACA and such minimal coverage on the Medicaid population, which is serving so many more people?
That's an interesting question. I mean, I think that Chad made a good point that the Medicaid issue is a little bit undercovered. I think part of it is that the creation of the exchanges and the regulation of the individual market was so controversial. Care that has to be ripped up root and branch. So I think it does attract an awful lot of attention. But I think that if the Senate passes something and there is a course charted for going to per capita cap and sunsetting the expansion, I think that the dollars there are just huge, and we're going to hear an enormous amount about that when there's something concrete to work with.
I thought about that. I think as journalists, we have a bit of an institutional problem. So when I was in the newsroom at the LA Times, so traditionally I was the business reporter. I wrote about private health insurance, and normally there's a metro reporter who traditionally covered Medicaid. And I think just many news organizations, we kind of split it up, and to some degree, the ACA scrambled all of this. And to me, increasingly, Medicaid is a business story as health plans take over in terms of managed care and lots of money. And obviously, it's a political story. So I just think traditionally newsrooms maybe haven't been set up, and we kind of split this story into silos, and we as reporters need to get up and walk across the newsroom and work together with a colleague, or just we need to do our homework and cover that story better.
The ACA and, quote, Obamacare exchanges failed to, et cetera, even when the news is market-wise and not exchange-specific. What are your thoughts about that?
Well, this is Cece, and I would say, you know, I certainly sympathize with today's reporters who have a lot on their plate, and you know, you're trying to do social media and write your stories, and you're on 24/7, and there is a lot of complexity to healthcare and healthcare reporting, and so some of it probably does get shorthanded in a way that does not make clear that there are these different lines of business or markets within our total healthcare system here in the United States. So I think finding ways to kind of get it up high in your story, just the quick sentence or two that indicates, you know, this is about the individual market, which represents X% of, you know, our home state or the total national picture or something like that, or little signals for your readers would be very beneficial. But I certainly sympathize with you all because it's a lot to cover.
Yeah, I mean, just as a journalist and self-reflection, you know, the use of Obamacare in headlines as a catch-all, I think I understand why, and I've certainly used it many times, but yeah, it as a catch-all word, it sometimes can do a disservice to what's really going on. And I think Catherine made a great point about just look back, you know, lack of competition or rising costs or consolidation, market power. And so I think that's just a good reminder that the ACA didn't solve a lot of those things. Sometimes as it was written, was never intended to solve some.
I have a question for Cece, and also Chad may want to weigh in on this one, which is, you know, Cece, you've come at this from both sides. You're in the insurance industry now, and before you're a reporter. And for many journalists, the insurance industry is kind of a black box, something they're intimidated about. So they tend to report more on the politics or the consumers. You mentioned taking executives out for coffee, but what are the kinds of questions that reporters should be asking insurance executives about, and how can they get deeper into that world to enrich their stories? And Chad, if you have some ideas too, I know folks would welcome that.
Well, you know, certainly starting at the beginning and trying to say, look, I'm pretty new to the health insurance business. Can you walk me through what your member profile looks like? So first of all, understanding any given company in your community or that you want to write about, are they primarily a Medicaid plan or Medicare, or are they really focused on the employer-based market? Because that will immediately signal to you where they're spending their time and their energy and what kind of expertise they have and or where their revenue comes from. So understanding that is very important. In my view, there is a difference in a business that is not-for-profit versus for-profit. It's just a simple fact that when you have to answer quarterly to shareholders, you have a different set of pressures and expectations, as opposed to being a nonprofit in a community, a very different set of pressures and expectations. I also think that currently asking plans about their relationships with providers can get at what I think, sadly, we are losing momentum in this country in the movement from volume to value. And I'm quite concerned that for a whole host of reasons, this system is going to remain very entrenched in fee-for-service. And in our view, the fee-for-service current system does not serve patients well. It does not serve federal taxpayers well. We are not pursuing value and time. You'll learn a lot.
Yeah, I would endorse everything Cece said about, yeah, just doing your initial homework, because companies can be far different in terms of, you know, some don't have any Medicaid business. a huge part of them, just ask for an interview with the CEO. I mean, right now, health insurers have been pretty quiet. How do they feel about the GOP bill pending right now? And that can just be an instant story. And back to her other point on fee for service, yeah, I think people would be surprised how much of the healthcare system is still fee for service, despite all the talk about moving in a different direction. And then just finally with health insurers, I find them fascinating because they touch all these different parts of the system. They are dealing every day with doctors, hospitals, with drug makers, with their formulary of drugs. So, they're key because they have data, they talk to all these different, they have a window on all of it. And so it's a great place to get.
I think we may have lost Catherine. I don't know,
I'm here. I'm
CC.
here.
Oh, you're there.
I'm
Maybe
here.
you were muted. Okay. Did you want to try and answer that one?
For a while though. Were you saying something?
I'm sorry. Did you ask me to repeat the question?
Yeah. Good night.
Okay. And just so you know, your voice is a bit uneven right now. But let me repeat the question. You expressed optimism in a Senate HCA bill possibly getting passed. Will you discuss if you believe that it will be similar enough to the House bill in order to be reconciled and achieve full passage?
Well, that's a really, really tough question. What I have learned from reading media and talking to people that are closer to it is, that it would certainly have to be quite a bit more generous than the House bill to have a ghost of a chance of passing the Senate. And I've heard people say that if the Senate passes something, the House is going to accept it. And I do sort of feel like there's a strong urge to accomplish something. So it might be the case that something that would get through both houses would be, much more generous than what the House originally passed. But I also think that there are many other equally likely outcomes, like nothing getting passed or something dying in conference. So, I don't have an inside track on that, but that's just what some things I've heard lately is that the Senate's a little bit encouraged with their progress and that the House is apt to go along with whatever the Senate can agree on.
Great. And with that, we're going to conclude our webinar. Just so you know, we'll be sending out an archive version of this, and everybody's PowerPoints will be up on our site, centerforhealthjournalism.org. You'll also be receiving a survey shortly, and we ask you if you can take a moment to fill that out. It tells us what works for you as a participant and what other topics you'd like to see in the future. Thank you so much to our panelists and to you, our participants. Bye-bye.
Thank you.